So now the conference morning session will start now. So the first session will be co-chaired by Vice President of Xu Huihen, who is the Vice President of National Health Research Institutes. And another chair will be Professor Xu Zhicheng, who is the Executive Director of NHRI. So let's welcome them.
So good morning. This morning session will be chaired by myself and Professor and Dr. Xu Zhicheng. Another co-chair, Professor Lin Zhengjie, he had a personal conflict, cannot attend this morning. So I particularly appreciate Professor Xu. He actually the key person to organize this international conference. So without any delay, let me introduce our first guest speaker, Professor Kenji Toba. Professor Kenji Toba is the executive advisor to the president of the National Center for Geriatrics and Gerontology, NCGG in Japan. And currently, he is the CEO of Tokyo Metropolitan Institute for Geriatrics and Gerontology. Those are TMIG. And furthermore, he's the chair-elect of the IAGG-AOR. I heard he had a very successful conference in Yokohama these 3 years. So today we are honored to have Professor Toba to deliver the speech of Japan's Dementia Basic Law 2023. This act actually in particular importance aim to help people with dementia and their dignity and live in a life of comfort. So according to the Japanese government estimate, there will be about 7 million people in Japan with dementia, or about 1 in 5 people over the age of 65 will be suffering from dementia by the time of 2025. So as we know, this situation could happen in any aging society. So it is valuable to learn from Japan's experiences in addressing these issues. So ladies and gentlemen, please join me to welcome Professor Kenji Toba.
Good morning, everyone. Thank you for introducing me so kindly. I will start the session, my speak. Today, I would like to introduce recent movement of Japanese government for healthy longevity and Dementia Act. My working place, Tokyo Metropolitan Institute for Geriatrics and Gerontology, was established 152 years ago by Eiichi Shibusawa. His photo will be printed in new 10,000 yen bill in 2024. In Southeast Asia, the shape of population pyramid of developing countries have been rapidly changing from triangle to bottle, as if chasing after super-aged society of Japan. And this figure is Tokyo Metropolitan. In the slide, horizontal axis show GDP per capita, and vertical axis show the average lifespan. Size of circle represents the population of the country. Japan shown in blue arrow show improvement of longevity by economic growth before World War II. This nice trend was broken by disaster of World War II in red arrow. At that time, the mean lifespan is only 30 years old. The economic bounce back recovery after World War II brought amazing increase in healthy life expectancy. These trends were accelerated by the introduction of universal health care, medical insurance of all nations in 1961. And further improvement was achieved by the introduction of long-term care insurance in 2000. Finally, two main challenges are dementia and frailty. Both of them are main target of geriatric medicine. This rapid aging in Asia influences the prevalence of dementia, increasing speed of dementia in East Asia is fastest in the world. It is amazing. The number of people with dementia in Japan is ever increasing. In 2040, the number of people who with dementia will be 9 million. Furthermore, the number of persons with mild cognitive impairment will be also 9 million. In a super-aged society, a small number of working people need to support persons with frailty or cognitive decline. Only 3 working people should support 1 dementia or MCI in 2040. The solution is only 2. First, increase the number of children. However, recent trend of the special total fertility rate in Asia Oceania region have decreased year by year. Second solution is increase the number of healthy older persons to work longer. Clearly, our mission is second. And to complete the mission, we need scientific, technological, and cultural wisdom to share with you. In January 2015, Japanese government announced a revised version of dementia measure, so-called New Orange Plan. Final hearing after integration of public comment, Prime Minister Abe invited medical representative Yokokura, President of Japan Medical Association, as well as research representative Toba. At that time, I worked for NCGG. December 2018, Cabinet meeting for promoting dementia measure was held. New Orange Plan was revised and upgraded June 2019. Along with the new framework on dementia care, I have chaired the expert meeting of new framework on dementia care. Finally, this year, during the Asian Congress 2023, Dementia Control Act, so-called Basic Law, done. Expert meeting chaired by Prime Minister Kishida for the law has started from September 2023. It's a very small photo. However, you can see the Professor Iwatsubo here, and me, and see the person with cognitive decline, early onset Alzheimer disease, Miss Fujita. This is I'll try so busy slide, I'm sorry. The aim is to obtain well-being of persons with cognitive decline, paying attention to their dignity by promoting prevention of dementia. And the mission of the policy is person-centered against stigma, living well in the community. And it's important, jurisdiction of law, the local government and local government, provider of medical welfare service, and also all Japanese people. And in the please see the third, education, barrier-free job, and prevention, education, early detection, early service. And the promotion of research include prevention, diagnosis, therapy, rehabilitation, and long-term care. And finally, it's very important, Prime Minister is the top of the policy promoting headquarters. Headquarters is responsible to establish the dementia measure and timetable. However, for example, Japan has advantages such as nationwide healthcare insurance and long-term care insurance, and for clinical research, imaging infrastructure is quite rich in Japan. For example, MRI is much frequent compared to the United States. On the other hand, number of people with dementia in OECD countries is shown in light upper panel. Japan has almost same number as USA and 3 times larger than UK, Germany, and France. However, research investing money is much smaller, much smaller than European countries. Recently, USA increased public research money for dementia up to more than $2,000 million. This figure is 100 times greater than Japan. In Japanese, very small quantities compared as suzume no namida, or teardrops of sparrow, which means drops in the bucket. We repeatedly asked government to change the policy of public research money, but the good news, some kind of grant go to the NCGG, I heard yesterday. By the great help of Tokyo Metropolitan Government, we established the Integrated Research Initiative for Living Well with Dementia as the Tokyo Metropolitan Institute for Geriatrics and Gerontology, started in 2020. In the iLied project, we have newly started collecting biological samples and medical information from healthy elderly individuals in the community and MCI patients in hospitals with their consent. Biological samples such as plasma, serum, CSF, and brain stored with quality control of biobank and brain bank. Some Taiwanese researchers are coming to our center and looking around the brain bank. Accompanying medical information and omics data as a data bank can be utilized for research institutions. In development, utilizing AI, we are making progress in diagnostic assistance using image information, facial expression, and the development of emotional support, conversational robot. I shortly can introduce today. Then I talk about early detection and prevention. Lancet Committee has revised the infographics, adding new risks such as alcohol consumption in middle life and air pollution in later life. Anyway, at least 1/3 of Alzheimer's disease can be prevented or delayed, reducing risks during whole life. Incidence of dementia has been decreased in main OECD countries. These results encourage the Dementia Preventive Action Plan. Prevalence of dementia has also decreased in UK, USA, Germany, and Spain. On the other hand, in Japan and Sweden, prevalence of dementia was still increasing. But we got a very good news. By Hisayama-cho study, most famous longitudinal cohort study in Japan, prevalence of dementia begins to decrease. The incidence of dementia will be affected by prevalence of risks. How is the trend in Japan? Diabetes mellitus secularly increased both men and women. Hypertension in middle age was improved in women, but not in men. Similarly, obesity was less frequent in women, but increased in men. Smoking is secularly decreased both men and women. Frequency and mean time of exercise are increasing year by year. Average years of education has been longer and there are no sex differences. Thus, especially in women, except diabetes, risks for dementia have been reduced. These data suggest in near future, the incidence of dementia will be smaller than before, at least in women. So far, the data from National Long-Term Care Insurance is a signal for coming decreasing incidence of dementia. This slide shows the incidence of moderate to severe dementia who need assistance for activity of daily living, except over 95 years old, incidence of dementia was decreased during recent 3 years. Similarly, in the United States, in 5.4 million older people over 65, number of persons with serious cognitive dysfunction decreased by 13% in men and 23% in women in recent 10 years. We would like to know the mechanisms underlying the decrease in the incidence of Alzheimer's disease. In the community, about 30% of mild cognitive impairment will revert to cognitive normal. On the other hand, in the clinic, only 10% or more are reverted, and 10% of MCI are converted to dementia. We would like to know the reason of these differences by using brain imaging and biomarkers. Several years ago, a research group of NCGG, including me, has reported a novel plasma biomarker for Alzheimer's disease in Nature. Notably, the biomarker predicts the positivity of amyloid deposition, which was determined by PET, about 90% accuracy. And the area under the curve was so high, about 95%, shown in this slide, compared with the Nobel Prize winner Koichi Tanaka. For CSF biomarker, P-tau181 is a good differential biomarker of AD from other main causes of dementia such as DLB and FTLD. Recent good news is CSF biomarker amyloid and tau was covered by National Health Insurance next January. To address these immediate medical needs, IRIDE is developing simple and accurate biomarkers in collaboration with companies. As a specific example, we are advancing clinical research on the early detection method for dementia using eyeglass type wearable with eye movement sensor and olfactory system. Another wearable watch project was presented tomorrow by Professor Obuchi. In our center, several PET studies only for research-oriented diagnosis are available. These include not only FDG metabolic imaging, amyloid imaging, tau imaging, but also astrocyte imaging for differential diagnosis of non-AD neurodegenerative disorders. This is ongoing determination of MCI reversion and conversion project. Participants take examination for determining amyloid tau and neurodegenerative classification, ATN classification by amyloid imaging, MRI, and biomarkers. Further, using a new neuroimaging technique, we'd like to find out early stage of other neurodegenerative disorders. Please see this area. You can see the AGD disease and semantic type FTLD and CBD and small infection, PSP, and behavior type FTLB, so-called PIC disease. We can discriminate such a so many number of neurodegenerative disease by using this astroglia imaging. So far, 400 or more participants gathered. We are cooperated with NCG by Professor Arai. NCGG participants much more, maybe 500 people. Total 900 people joined this reversion and conversion project, longitudinal study. So big project. I already got 100 more imaging. We would like to show you your preliminary data of amyloid imaging in 149 cases of normal control or MCI. About 10% are early stage or preclinical AD, On the other hand, 2/3 of subjects are normal or non-AD by PET imaging and MRI-oriented neurodegenerative detection. These results can partly explain the difference of the rate of revert between community and clinic. Then I talk about dementia in place and prevention of BPSD. Although Japanese government, Ministry of Health and Welfare, prepared a lot of structure-based systems. However, caregivers and persons with dementia were not satisfied by the service because of the service is not enough for the difficulty and to secure calm and active life in the community. We need more, another. Most serious problem and challenges dementia in place is lack of care workers in care institutions covered by long-term care insurance. Already, the number of shortage is more than 200,000. This figure will be tripled in 2045. In response to the lack of public care resources, in 2090, 100,000 people decided to leave their job because of care for their parents. It's very serious. Responding to this situation, we have developed an AI-assisted chatbot. Using reminiscence method, we taught the main information of the user, such as the birth and the birthplace, and the famous product and the festival or birthplace. User and chatbot started to conversate, and AI learns and gathers more information related to the user. Preliminary impression of the user with cognitive decline is fun. Caregivers told me he spoke much more actively than in home. Clinical trial has just started this fall.
23日
It's my voice. Because recently I
鳥羽健二さん、お
recognize
誕
my
生日は4月
forgetfulness.
23日ですね。よろしくお願いします。残暑も和らぎ過ごしやすくなりましたね。
まだまだ暑いです。
We talk more than 15 or 20 minutes to conversate. So
はい。
両国国技館へ見に行ったことありますか？
I'll skip this. Thus, age-friendly or dementia in place is complex with a lot of challenges. These challenges wait every related people to join. In Oba City, where National Center for Geriatrics and Gerontology locates, not only medical and welfare sector, but administration, bank, insurance, light, gas and water, delivery bus, taxi, and media has joined to create dementia in place. During group working, they discussed their role and possible contribution. Their consciousness were altered, get real awareness. This is the final slide. Finally, in response to limited and decreasing human resources for dementia, we have started to social resource repositioning. These resources, located unanimously all over Japan, can be alternative dementia care power by education and enlightenment. For example, dementia support doctors, the number is counted more than 20,000, are distributed all over Japan. They work as teachers for general practitioners about dementia diagnosis and care. Lack of space for social inclusion for persons with dementia, we proposed and examined the effectiveness of sermon and coordination of talk in their temple rooms. We hope in future these utilization of new resources can be new biomarker as social resource repositioning. Thank you for your attention.
Okay, thank you, Professor Toba. And review of your successful implementation of the basic law for dementia in Japan. So several new biomarkers and image study, and he also pointed to the main challenge in front of us, how to proceed and continue the dementia research. Let's give him a big applause again for your excellent speech. Thank you. So it's my great honor to introduce our second speaker, which will be delivered by Professor Gustavo Duque. Professor Duque is the chair in geriatric medicine and director of Luis in McGill Center of Excellency in Sustainable Health for Seniors at McGill University in Canada. Today we are privileged to have him give a lecture entitled Geroscience's approach to the development of biomarkers for age-related diseases. Actually, in aging society, achieving healthy aging has been always a key goal. But it's not just about living longer. It's about slowing down the effect of aging on our bodies and keep things working smoothly as we get older. So the Geroscience's approach focuses on slowing down the aging process itself and could help to prevent or delay many different age-related diseases at the same time. So ladies and gentlemen, please join me to welcome Professor Duque.
Thank you very much, Mr. Chair, for the nice introduction. It's a pleasure to be here in Taiwan. I love coming here. When I received this kind invitation, I was very happy because this is a great opportunity to have a very solid scientific exchange, but at the same time to catch up with very good friends not only from here, from Taiwan, but also from all over Asia. So today we're going to talk a little bit about the geroscience approach and how we understand the development of biomarkers from the geroscience perspective. And I'm sure that you are familiar with the way of how biomarkers are validated and developed. You know that there is first the biomarker discovery, which involves the biological demonstration that there is an association between a disease or several diseases and a biological phenomenon. And this is demonstrated, and here you can see some of the challenges that people find to do that, and we find that in the lab is demonstrated usually by animal models or biological samples, and then we have to go into the analytical validation, which goes into groups that may have the disease or may have the condition or several conditions, and we can demonstrate that there is the presence of the biomarker is there. There are biomarkers that we can demonstrate are indicators of good health, and other biomarkers that are indicators of predictors of adverse outcomes and disease. And then the clinical validation, which usually we do through cohorts, and the previous presentation was a clear example of how we identify these biomarkers in this kind of cohorts, and then the regulatory qualification, approval, and use in practice. What I'm going to show today, and I'm going to share some of the studies that we have done so far at McGill, and when I was in Melbourne and in Australia before, most of these biomarkers have reached the point of clinical validation. So I didn't want to bring biomarkers that are already established in clinical practice, because I think that for the purposes of this conference, I think that I would like to share with you the new upcoming biomarkers. And for those of you who are not familiar with the concept of geroscience, this is becoming a hot topic now in geriatric medicine. The concept is relatively simple, is that through geroscience, we look at different mechanisms, biological mechanisms, that are shared by several age-related conditions. So we don't look at, and from the geroscience perspective, we don't look at separate entities, separate diseases, and try to look at biomarkers for that separate disease. or therapies for the separate diseases, we try to identify through the biological components, we try to identify treatments and, of course, biomarkers that will facilitate the interventions that target several conditions at the same time. It's cost-effective, and we think that is probably the future of geriatric medicine. And geroscience, the concept of geroscience goes around these, what we call the hallmarks of aging. So you can see, initially there were 6, now there were like 8, and now I think there are 12, and hopefully we're not going to increase it more, because then we will have to, you know, we'll make the geroscience field very complex. But you can see some of these are, for instance, dysbiosis, which relates a lot of microbiome. You can see genomic instability. So I will not go into all of these, mitochondrial dysfunction, because I was looking at the program for this conference, and several of the presentations will relate to one or a few of these hallmarks of aging. What I will try to do in this 20 minutes or so, I'm going to share with you some examples of how we have approached and how we have tried to develop some biomarkers using or targeting these new hallmarks of aging. So the first one, for instance, just to give you a first example, is fat. Fat infiltration, and here the example, because my lab works a lot on muscle and bone, but this is, I brought you some examples that we understand that when fat infiltrates, and this, I'm not talking here about obesity, I'm talking here about this fat that is abnormal, that infiltrates the muscle and bone, for instance, and I will show you also a couple of examples of other organs that are infiltrated by fat. But at the same time, we know that it relates to inflammation, it relates to metabolic dysfunction, and nutrient sensing that is affected. So these are 3 hallmarks that we can target just by measuring fat or characterizing the fat that infiltrates the muscle and bone. And why is that important? Well, because we know that fat cells that infiltrate these organs come from the same precursor, the mesenchymal stem cell. So if the mesenchymal stem cell is affected by aging or by the disease, then we are going to have a predominant differentiation of those cells into fat. And that fat starts infiltrating the muscle, bone, and interestingly, it starts infiltrating other organs. So if we have less differentiation of stem cells into fat, let's say we have healthy bones and healthy muscle, so the presence or absence of fat in those organs will be a good indicator of healthy aging and healthy longevity. So, and this is what we see, you know, when we look at a sarcopenic muscle, this is what we see, lots of fat infiltrating not only around the muscle, but also inside the fiber. We have the same phenomenon in the bone marrow of osteoporotic bone. And what we did, trying to understand and to identify what are the consequences of this fat in these organs, and also trying to identify whether we can use fat as a biomarker for health-related conditions, because again, it has a very strong inflammatory effect. So what we did was we evaluated the fat content. We did a complete lipidomic analysis. This is in mice, in aged mice, of fat that infiltrates the muscle, fat that infiltrates the bone, and we compare it to the serum lipids. And basically what we found is that marrow and muscular fat are very similar, very toxic, and very inflammatory. That approach allowed us to identify potential components of this fat that we can in the future, and at this moment we are evaluating that in humans, we can understand and use as a biomarker for at least for 2 or 3 different age-related conditions. And because their similarities, what happened in the bone with the presence of this fat versus what happens in the muscle in the presence of the fat is very similar. It's a catabolic state, inflammatory state, lipotoxic state. As I say, we are trying to identify which are those pro-inflammatory specific factors that are present in the fat at the same time in muscle and bone that deteriorates the function of these organs and also affect other organs and in general induce systemic inflammation. But that's not the only thing we do. We also try to quantify it. It's not only to look at the composition, but we can measure it. Now we're using a software that can quantify the bone marrow fat, all the yellow components here, in any imaging, in CT scans, in MRIs, we can quantify it and we can determine the risk of having adverse events by quantifying the fat infiltration, not only in bone, but also in muscle, just with imaging. Something that we developed also with, as another way of approaching it is this is a collaboration with a group in Norway, Dag Arsland and his group. They have these longitudinal cohorts in dementia. And we say, okay, why not quantify fat infiltration in the masseters or in the tongue as a biomarker for deterioration and dementia, people with dementia, or a predictor of adverse outcomes in older persons living with dementia. And we have been able to demonstrate with high accuracy, this is a paper is in press at this moment in the Journal of Cachexia, Sarcopenia and Muscle, that just by measuring fat infiltration in the tongue and in the masseters, we are able to predict adverse outcomes in these patients. The next step now is to use and profit from artificial intelligence and deep learning. So now we have a deep learning model that we validated that can analyze around 2,000 scans per week and is able to predict all these adverse events in longitudinal cohorts. So I invite you, you have in your cohorts, you have imaging and you are interested on helping us to validate this deep learning model, you are more than welcome to contact me and collaborate. Second example, tryptophan metabolism. I will go quicker here, but we know that tryptophan is an amino acid that is essential, that is metabolized by the microbiota. So we have this biosis, the metabolism of this tryptophan will be affected. We know that in high levels of inflammation, we also have alterations. And why is that important? Why we look at tryptophan? Well, this is a very interesting example of how there is a connection between the gut and the brain, because the tryptophan is metabolized into serotonin, which is probably the better known metabolite of tryptophan, but it's also a metabolite, or mostly metabolite, through the kynurenine pathway. And what happens when we have a situation when there is bad aging, when there is a lot of inflammation, when we have a dysfunctional microbiota? Well, what we have is that a lot of kynurenine is produced, and kynurenine is a terrible metabolite that is clearly associated with unhealthy aging, because it affects different components of aging. It affects stem cells. So remember that stem cells depletion, that is one of the hallmarks of aging. It also associates with chronic inflammation or inflammation. So if we have too much kynurenine, we have unhealthy aging. What we have also looked at is that tryptophan has also a good metabolite, that is the picolinic acid, one of the N metabolites. So in conditions of healthy aging, healthy microbiota, not in too much inflammation, the pathway ends up producing metabolites that are anabolic, which we have demonstrated to be anabolic in bone. I will not go into all the details. And we have been demonstrated that it's anabolic in muscle. So if we have good levels of this anti-inflammatory, antioxidant, anabolic metabolites from the tryptophan, then we can demonstrate that it has a biological impact on healthy aging. So what we have done in humans, we have evaluated more than 14 metabolites of the kynurenine pathway, and we have been able to demonstrate and to validate these metabolites as indicators or predictors of adverse outcomes, as an indicator of healthy aging. So we have, as I already mentioned, all these ratios that are anabolic. Then we have better function, mobility, and less frailty. If we have the more kynurenine type of metabolites, we have unhealthy aging, and we have more frailty. So this is another example of this kind of the use of geroscience to identify that. The next one, again very quickly, stem cells exhaustion, which is one of the major ones that I have already mentioned before. And for this, I have done these studies with my postdoc, Jack Feehan, which, by the way, is not my son, but he's my postdoc. He did a PhD only on these kind of stem cells. We focus on these particular populations, circulating osteoprogenitors, known as COP cells. These are very interesting cells. These COP cells are in the circulation. They come from the bone marrow. Now we know that they come from the bone marrow. They are stem cells that are in the circulation, that are in our bloodstream, and we can quantify it by flow cytometry. Very simple way to do it. Why we are interested in this as an indicator of stem cell exhaustion with aging? Because we have found that low levels of COP cells are associated with osteosarcopenia, with low bone and muscle mass. We know that low levels of COP cells are associated with frailty. We already published that a while ago. So this could be an indicator, a good biomarker of healthy and unhealthy aging, particularly in the context of mobility, osteosarcopenia, and frailty. So this is a recent paper that we summarized. In this paper, we summarize all the evidence that we have at this moment. We have already characterized these cells. We know that there are stem cells. They go down with aging, but particularly they go down mostly with unhealthy aging. And to finalize, we have the final group, or the other group of biomarkers that we are exploring from the geroscience perspective, which is telomerase activity and epigenetic clock. So we know that there are epigenetic alterations, there is telomere alterations as well in unhealthy aging. So we are looking at this moment at two very interesting biomarkers. One of them is the Dunedin pace, which is a DNA methylation, which seems to be the best predictor of adverse outcomes. It's becoming a very hot topic at this moment. And we are, through different cohorts, very much longitudinal cohorts, we have collected data so far, including the UK Biobank and other big biobanks. We have collected data from about 1.2 million people, where we are analyzing all these biomarkers, particularly from the perspective of the DNA methylation, but also, and I will just go straight to this one, also we have just finalized this study from the UK Biobank, analyzing 20,000 participants in the UK Biobank, where we found that telomere length was positively associated with greater muscle volume in both sexes, and interestingly, it's a very good indicator of healthy aging. So if we have good telomere length, definitely we have better muscle mass, mobility, independence, and less frailty. So I just wanted to share with you 4 examples of what we are doing at this moment from the geroscience perspective. So the geroscience approach could provide a set of robust biomarkers. If we look from this perspective of different components of hallmarks of aging, most of the methods are already there, so we don't have to create the methods. We just have to provide the samples and get the good rationale, and we can use all these longitudinal cohort studies. So with this, I would like to thank you again for the invitation, and in particular thanks to all our collaborators around the world who have helped us to develop these studies, and of course and thank to the people who paid the bill for all these studies. Thank you very much for your attention.
So thank you, Professor Dance, for your excellent speech covering the new potential biomarker in the aging studies. So again, please keep your question until the panel discussions.
Let me introduce our third speaker, Professor John Morris. Professor John Morris is a distinguished professor of neurology at Washington University School of Medicine, USA. He is also the director of Charles and Joanne Knight Alzheimer's Disease Research Center. It's our honor and a pleasure to have Professor Morris to give us a lecture about Alzheimer's biomarkers in healthy aging predict cognitive neuropathological outcomes. Professor Morris' research focuses in dementia, geriatric neurology, neurodegenerative disease, and cognitive function. He will discuss the use of the molecular biomarkers, specifically A-beta and tau proteins, as a reliable indicators for Alzheimer's disease neuropathology, even in asymptomatic individuals. Let's welcome Professor Morris.
Well, thank you very much for the invitation to join this very this conference. I'd like to thank particularly National Health Research Institute and the other sponsors, as well as the organizing committee. So here are my disclosures. Our research is supported primarily by grants from the National Institute on Aging, part of the National Institutes of Health in Bethesda, Maryland, and have no conflicts with pharma or biotech companies. I want to acknowledge that I think a reason that I'm here is because of my association with John Yang from Kaohsiung University. John came to visit us in 2000. So we've had a long and productive association, and I thank him very much for his support. Information that I'm going to present here today, of course, are done by a team at Washington University in the Knight Alzheimer's Disease Research Center, and I want to acknowledge particularly Tammy Benzinger, Rick Perrin, Suzanne Schindler, Kenji Zhang, and Justin Long. And Justin published the data that I'll be presenting in the first part of this presentation. So the purpose of this conference in large part is to try to think of ways and develop strategies to promote a vital and geriatric society, so that we have people who are thriving rather than than affected by disease. And of course, we have to address then, to achieve that goal, really global aging health issues. And among those health issues, one of the most, perhaps the most challenging, is that of Alzheimer's disease. So we, over the past 2 or so decades, have developed a paradigm wherein we look at Alzheimer's disease as a entity that really has a long asymptomatic period. We call it preclinical Alzheimer's disease, wherein the pathophysiologic changes are beginning in the brain but have not yet caused enough neuronal or synaptic damage such that brain function fails and dementia appears. The reason we've been able to identify this preclinical Alzheimer's disease in cognitively normal older adults is because in the past 2 decades or so, we've introduced molecular biomarkers of this pathophysiologic Alzheimer process, both imaging biomarkers as well as fluid biomarkers, primarily cerebral spinal fluid. And we know that the first abnormality is a dysregulation of amyloid levels in the cerebral spinal fluid. And as I say, this may begin some 20 or more years before dementia appears. It is then followed by amyloid imaging positivity, and then later on by elevation of cerebral spinal fluid tau. So in this paradigm, the symptomatic phase of Alzheimer's disease, which lasts some 7 to 10 years, is really the end stage of this long process. And although there now is hope for disease-modifying therapies for people with symptomatic Alzheimer's disease, Our idea is it would be much more effective to try to prevent this end-stage symptomatic phase of Alzheimer's disease by identifying the preclinical stage of Alzheimer's using biomarkers and then intervening with agents that can halt this pathophysiologic process and at least delay, if not prevent, Alzheimer's dementia. So the molecular biomarkers of Alzheimer's disease include amyloid and tau PET imaging, as well as cerebrospinal fluid, and now plasma measures of the major proteins that are disrupted, amyloid beta and tau. We know that using biomarkers that about 30% of cognitively normal people age 70 and over are positive for one or more of these biomarkers. The question is, when in the lifespan do the biomarkers first become apparent? And as I mentioned, we think this is at least 20 years before symptoms occur. So if people over 70 are the predominant age at which people dement, that means the biomarker positivity may begin at age 50 or even younger. So we have always been studying people 65 and older, but for the past 20 years, we've initiated an adult children's study of middle-aged individuals, age 40 and over, and in fact can find amyloid abnormality beginning at about age 45. Biomarker positivity is now mandatory for individuals who want to participate in clinical trials of potential Alzheimer therapies, and now for the approved disease-modifying therapies for Alzheimer's disease. The first such drug, lecanemab, was approved in the United States in July of this year. But you must demonstrate that people have abnormal amyloid, because lecanemab is an anti-amyloid antibody, and you don't want to administer it to people who do not have the target. So we use biomarkers quite a bit to understand the course of Alzheimer's disease and now for therapeutic purposes. But few studies have validated these molecular biomarkers with the cognitive and neuropathologic outcomes. So that's what I'd like to present here. A study of cognitively normal individuals who had one or both of the imaging and fluid biomarkers. These individuals were aged 42 to 91 at their initial examination. They either had amyloid PET scan or they had CSF measures. We used the phosphorylated tau at 181 to A beta 42 ratio to identify people with a positive biomarker signal for Alzheimer's disease. So we assessed whether these individuals who had biomarkers and were positive, did they progress to cognitive impairment? Eventually, and for those who came to autopsy, did they have the neuropathologic findings of Alzheimer's disease? We used the Alzheimer's disease neuropathologic change criteria and required them to have at least intermediate or high likelihood that the Alzheimer's pathology was responsible for the dementia. So these are the demographic characteristics of these individuals in this particular study. We had a total of 720, of whom 79% were biomarker negative and 22% were biomarker positive. The biomarker negative individuals, as expected, were younger and had less likelihood of carrying an ApoE4 genotype than the biomarker positive individuals. Note that the mean educational attainment for this sample is essentially a college degree, 16 years of education in both, so this is not a sample that is representative of the general population. There were no sex differences in these two groups, biomarker positive and biomarker negative, it was predominantly a non-Hispanic white population. About 50% had both amyloid PET and CSF. if they had only one biomarker, they were more likely to have amyloid PET than they were to have cerebrospinal fluid biomarkers. So over time, about 34% of the cognitively normal biomarker positive participants did develop dementia versus about 8% of the biomarker negative participants. For those individuals who were biomarker positive and became demented, the clinical diagnosis was that of Alzheimer's disease in 80%, whereas for the biomarker negative people, it was only 55%. So other factors may be contributing to the progression to dementia in the biomarker negative individuals. Neuropathologic outcomes, so we had 82 of the 720 individuals die during the study. And of those 82, 70% or number 57 came to autopsy. And here, 91% of the biomarker positive participants had intermediate or high Alzheimer's disease neuropathologic change versus only 8.6% of the biomarker negative persons. Now, if you look here, these are false positive individuals. That is, they were biomarker negative, but did not have sufficient neuropathologic change to meet our criteria for Alzheimer's disease. But notice, this is on amyloid PET, that they are at the very threshold for positivity, so this may be a threshold issue. So for the sensitivity and specificity characterization, individuals in the total sample using both amyloid PET and cerebrospinal fluid had, for predicting neuropathologic Alzheimer's disease, sensitivity was 87%, specificity 94%. If we use the CSF ratio of p-tau 181 to A-beta 42, note that the specificity is 100%. So we did have a false negative and 2 false positive cases. I've already mentioned that the false negative cases were very close to the cutoff for amyloid positivity, so may suggest that we should change that cutoff value. And I mentioned that the clinical diagnoses in the biomarker negative people who progressed to CDR greater than 0 had clinical diagnoses of non-Alzheimer's disease much more frequently than our biomarker positive people. And we found that neuropathologically as well. For the biomarker positive people, non-Alzheimer pathologies were infrequent, whereas among the biomarker negative people who progressed, they had vascular lesions, TDP-43, and synucleinopathy. So we concluded that preclinical Alzheimer's disease biomarkers are associated with a significantly increased risk of developing dementia and are highly predictive of intermediate to high Alzheimer's disease neuropathologic change. Now, some of our biomarker positive people did not progress over the time period of our study, and some of them stayed CDR0 for more than 15 years, and this is just consistent with the fact that the duration of preclinical Alzheimer's disease may be 20 years or even longer. Of course, these individuals also may have factors that give their brain resilience to the neuropathologic changes. Now, I already indicated that our sample is not representative of the population, and we do need to study the frequency and predictive value of biomarkers in minoritized groups, not just in non-Hispanic white individuals. And already the little data that we do have that begins to emerge suggests that Black and Hispanic individuals have overall a higher rate of dementia compared to non-Hispanic individuals. But the paradox is, in a few studies, and there have only been a few, Black and Hispanic individuals seem to have a lower rate of amyloid positivity and amyloid burden. So this is important because we want to incorporate Black participants in clinical trials of anti-amyloid or anti-Alzheimer drugs, but to be eligible for the trial, you have to be amyloid positive, and if Blacks have a lower rate of amyloid positivity, they will be underrepresented in the clinical trials. So why would this be the case? Why would, if they have more dementia than whites, why would they have less amyloid or Alzheimer pathophysiology? Well, there are selection biases that are at play. White participants may come from a different source than Black participants. And there is the increasing importance and attention to social determinants of health, particularly over a life course where experience of chronic discrimination and racism, lower quality of education may indicate increased risk for Alzheimer's disease. And there may also be genetic variants that affect the biology. And then finally, Blacks and Hispanics may have higher rates of other conditions, comorbidities, that may increase risk for non-Alzheimer forms of dementia. Now, I've shown here effective treatments, and I underscore for all patients. These are data from the lecanemab study, and note that that positivity, a positive response, is associated with most individuals, but not for individuals who are ApoE4 homozygous. In addition, note that younger people below 65 may not benefit from the drug, and individuals who are women also may not benefit from the drug, as well as individuals from non-white groups. So again, this is just underscoring the importance of enrolling individuals that represent the population, not just individuals who tend to come into studies such as the one I presented. Now, we have been, as I indicated, doing biomarker studies for 20 years in research cohorts. Now, with the advent of disease-modifying therapies, lecanemab is only the first, others are coming and soon. We must utilize biomarkers much more widely to find out who is eligible for therapy. Biomarker confirmation of amyloid pathology is mandatory in patients being considered for these new treatments. But PET scans are only available at academic medical centers. They're expensive, they have radiation. Cerebral spinal fluid requires spinal tap, lumbar puncture, and these are not going to be widely used in the population. And again, we need to study the entire population, not just individuals who volunteer for longitudinal research. So now there is great interest in and work being done on blood-based biomarkers, these promise much more rapid and accessible diagnosis to determine who is eligible for these treatments. Also, they likely will be much less expensive than PET scans and much more tolerated than a spinal tap. So we have been at Washington University, as well as many other centers, been examining blood-based biomarkers for Alzheimer's disease to determine amyloid status. There are many blood-based biomarker tests in clinical use or under development. I'll mention one because this was developed by my colleagues at Washington University, Dr. David Holtzman and Dr. Randall Bateman, where they had formed a company called C2N, which developed a blood-based biomarker using immunoprecipitation mass spectrometry. And the company has developed this test called Precivity, first based upon amyloid beta 42 to 40 with ApoE proteoforms, but now they've developed Precivity 2, which incorporates the amyloid beta 42 to 40 ratio, but also p-tau 217 and amyloid beta 42. And it has a very strong sensitivity and specificity. But many other companies and platforms are being developed to determine their utility for blood-based biomarkers for Alzheimer's disease. Now, in our hands, what we find is the various tests do show the strongest value for the plasma A-beta 42 to 40 and the p-tau 217. And combined, they have remarkable ability to identify amyloid positive individuals. This is just a overall view of what we can detect first. The the p-tau 217 in the cerebrospinal fluid seems to become abnormal first, some 21 years before people develop cognitive impairment, as indicated by estimated year of onset of impairment. But p-tau 181, which is much more widely used, is also very good at identifying the early stage of the disease. Both p-tau 217 and p-tau 181, even though they are based upon tau, are much better indicators of amyloid deposition than they are of tauopathy. So these are really measures of amyloid. p-tau 205 is a better indicator of tauopathy, p-tau 205. So we should develop these blood-based biomarkers because they will be much more accessible, much better tolerated, and hopefully much cheaper than PET scans and cerebrospinal fluid measures. We think that the p-tau 181 to A-beta 42 or the p-tau 217 are the best markers to determine in the CSF amyloid status, and in the plasma that p-tau 181 and p-tau 217 classify amyloid status at the earliest stage. So I think as more disease-modifying therapies come to be available and more individuals are being characterized to determine their eligibility for treatment, we'll see a corresponding increase in the acceptance of blood-based biomarkers for Alzheimer's disease. With that, I thank you for your attention.
Thank you. Thank you, Professor Morris. Excellent talk. He mentioned a lot of innovative biomarkers, including the amyloid and also blood-based biomarkers to detect early detection for the Alzheimer's disease. If you have any questions, please hold on the last section. We have a discussion section. Let me introduce our He is also the Vice Superintendent and Director of Memory and Aging Center at Kaohsiung Municipal Datong Hospital. Professor Yang's research focus is on the early dementia and the cognitive impairment, pharmacogenetics, and the genetic epidemiology. Today, we have an honor to have Professor Yang to give us a talk about the characteristic of adult children of patients having Alzheimer's dementia in Taiwan. He is going to share updates on his ongoing study about the clinical demographic characteristic, proteomics, and the cerebral PET findings. Let's welcome Dr. Yang.
Thank you for the kind introduction, Professor Xu. And before my talk, I would acknowledge the National Health Research Institute, and also my center, my university, and also especially to Washington University, my mentor, Professor John Morris. Before I talk, I want to thank John Morris again. After I leaving, he gave me a letter. So today, he kept his promise, come to Taiwan again for his committee. So I will say thank you, Dr. Morris. This is my main mission. We're talking about the association of family tree of dementia patients in Thailand, in Taiwan and the Asian country. And also we'll address the ApoG genotyping in adult children, plasma protein, amyloid PET, and also the digital intervention. It's a long story and old story. We know that dementia may be developed from 20 years ago before symptom onset. But where is the target? How we can manipulate this target? Maybe you can say that people have 50 years old with diabetes, with hypertension are under risk, but too many patients under risk. So we have to focus on some patients we can manipulate, we can interpret, and we can control. So we can focus on the family tree of dementia patient. We call adult children or AD patient. Actually, we use a uniform data set. The UDS developed from the NIA and ADRC American. There's known to a 3 version. The version 1, we use this version 1 on 2005. We use version 3 recently, so we got a copyright and published data under the UDS. I think the main purpose of UDS is should be collect data in a standard manner and uniform manner, because so many countries and so many ADRC in America in the world, we should share the data together. This one we published 10 years ago. We have registration data to recruit Asian countries together. At that time, we used the UDS version 1. So we recruit around 2,480 patients. We check in the family tree. Currently, 8 for female, 3 for male. It means the family tree is a strong indicator for having dementia in the near future in 80 patients. The data come from Taiwan. We have 6 centers to collect data. Come from Japan, from Sendai Tohoku University. And Korea University, also the Thailand, Philippines, Singapore, Indonesia, Hong Kong, and the China. So I think it's the first study to recruit the Asian countries together, which report a family tree of this patient. In their study, you can see in Taiwan, mother have dementia around 7, father 3, China 9, 3, Hong Kong 12. 3, Singapore, 8, 3, Indonesia, Korea, Japan. They have similar presentation, female predominant, around 8 or 3. Around 8, but father around 4. So this first study we complete the family tree of AD patient. Recently, we published another publication. We compared the 12-year comparison to check the family tree. This is very interesting in Taiwan. You can see here the most of them are children. They are higher educated, but the patient is not changing. The age is just around 56 or 57. This population could be the risk of dementia in the near future. I will show you the data. We compare the change of family tree after 12 years, that's consistently female predominant. And also the male also have a strong history for having dementia. So it means the dementia patient under risk of dementia is a consistent finding after the case examination in Taiwan. It's a study, I think everyone knows that already they onset dementia come from not only for identified gene, but a family tree is a strong indicator for having dementia. And even then have a family tree, then we have an early age of symptom onset. The first study I think come from Washington University in St. Louis. Now Professor John Morris of the United States American, and he told me this study. Then checking the biomarker, clinical history, and psychometry for the adult children of dementia patient, and tracking their clinical course. So then checking the patient from 45 to 74. This data come from WashU. But in Taiwan, we have modified this study because we don't have much more money. So we have to use the age focus on 50 to 74. These people are non-demented. We're tracking this annually psychometry, blood biomarker, 3D MRI, PET, EEG, and AI digital medicine longitudinal study. So I will share the data here. As people come to your clinic, we report the impairment cognition function. So, but we have made a small study to show you that patient report the data. They are true impairment. For instance, the CDR patient higher report the memory impairment, but actually they are impairment. So we trust the complaint. It's an interesting data. So when people when people CDR zero, but they report cognitive impairment, we measure they definitely have a positive. So in CDR zero patient we recruit, then definitely they report impairment, but then actually they are the impairment. So this is one of our criteria. We recruit a CDR zero patient, but a subject complaint memory impairment. So they are recruited to our study. How about the ApoE genotyping? You can see the ACS patient. The higher ApoE positive, similar to AD patient, but higher to normal control. We have this data. So in ApoE genotyping, maybe you can say the ACS is similar to AD in ApoE genotyping, higher to health control. And ApoE4 is quite different. It's higher in Taiwan, in AD Taiwan, but lower compared to Caucasian and Hispanic. So the ApoE4 is positive. It's around 30 in Taiwan. And also, this is very interesting here. The ApoE4 allele in Taiwan compared to Caucasian is low. Also lower to African American and Japanese, but similar to Hispanic. It's we have compared this data. How about the plasma level? Firstly, we use a very interesting new technique we call a micro-Western array to identify many proteomic studies. This is a patient we recruit. They are especially for the age. The AD around 80. This one around 60. This control. They are significant in the age. This is our result. We use the protein chip. We can tell the health control apart from ACS and AD. And also we use the proteomics. We can tell you ACS from AD. So currently we use this protein to identify patient ACS at risk of dementia. We have applied the pattern, so we're going to produce the protein chip. In the near future, use a protein chip, you can identify your ACS under risk of dementia. So this is our new cooperation with NHI. Also, you can look into the plasma biomarker. These are baseline data. For the age younger, around 55. It's a normal control. Is elderly similar to AD, and we also control a KD score. This score means the AD patient have less cardiovascular factor to develop AD. So if they become AD, the more contributing factor now come from cardiovascular. So definitely, if they become AD, they can maybe amyloid positive, but amyloid associated, not cardiovascular. You can look into this biomarker. You can hear for A-beta 40, 42, the AC is similar to AD, higher to normal control. Also for P1A1, similar to AD, higher to normal control. So in plasma level for A-beta 40, 41, and P1A1, the AC is similar to AD. So maybe I'm considering the AC may be underlying development AD, but without clinical so apparently. But in the near future, then maybe we will present the clinical picture of AD compared to normal control. So I trust the biomarker, especially for P1A1, could be a good indicator to predict this one. And we look into a very interesting one. We hypothesize that the A-beta 40 and 42 will produce and metabolized under equivalent state. Once this equivalent interrupt, the patient may be developing AD in the near future, but we have to examine this longitudinally. You can see here the normal control, A-beta 40 and 42 are highly correlated. AC correlated, but once the patient has dementia, the correlation interrupts. So maybe this produced metabolite can be equivalent, so patient will not have dementia. The correlation interrupt, maybe will become AD. This is our hypothesis. So far we use the proteomics, use a correlation between 40 and 42, A-beta 40 and 42 to tracking the AD patient. Also you can see the top 14. So that's plasma change. How about the amyloid PET in the AC patient? It's very high. This is a convenient sample from our AC patient. We have performed 18 amyloid PET, 8 have amyloid PET positive. It's a very big impact for this news. If this patient around 55 or 57, then amyloid PET positive beta blood biomarker. I don't know, maybe I can say in the soon near future, this patient will develop clinical AD. So I think the AC should be the target, or we should do something to prevent the auto intervention, high amyloid positive. And this amyloid positive not only by visual rating, we also have a very quantified measurement cooperated with the Japan Professor Mozuka. So this impact news for the general population, the adult children, high risk. So this is the development we use. And we heard about how to management. We have many non-pharma interventions, but today I will introduce a digital intervention. This data comes from MIT. They use 40 Hz gamma oscillation, the flicker, to treat this transgenic mice. The neuropathology will disappear or decrease after this intervention. And so then also remove this light outside the animal. The data probably in cell. The neuropathology will also decrease after such intervention. Then consider such a gamma intervention will illustrate the glial cell to phagocyte A-beta. So this is the annual study then completed at MIT. But after that, the professor tried to have become a CEO in the company. Then develop a device then called Cognito. This device that have a pilot study, then we will have a left ventricle dilatation and left hippocampus atrophy. Increase the functional connection in DMN and visual network. Better performance in delayed recall memory test, improve quality of life, then complete the human study. So I would say this is maybe a brand new, a new intervention for dementia in the near future. This is my personal lab. You can look. I will show you how the 40 Hz works. In my lab, we use the 40 Hz and sound and light to treat the cell, and we have a significant finding. We are quite different from the American. We try to develop our own technology. This is a 40 Hz light, but I also have a 40 Hz sound. You may consider the sound is noise, but it benefits for the cell. After such intervention, the cell will have an improvement. I'll show you data. We publish this data. This is a 40 Hz light. It flicker, make you uncomfortable. But in American, in MIT, they use this one to treat the patient. So some patients we have been uncomfortable during such intervention. This is our lab. We have do the lab many times. The P1A1 decrease, my sound and light. Also significant in A-beta 42 and 40. After that, we consider how we can make the light more comfortable. So one day, a Taiwan company, we got Delta company, they come to visit me after my talk. Then create a desk lamp. This lamp contains the 40 Hz, but it will not flicker. So people so far use this one are reading other desk lamp. We test this one also have a better function in decrease of P1A1 and other pathology marker or dementia patient. We publish and submit this data. This light can decrease the secretion of A-beta 42 and inhibit its aggregation in cell study. It also will increase the glial cell to phagocyte A-beta. We have completed this study and report this one. So we have also completed this human study. This desk lamp we use in the dementia care unit. We will use this one for 3 months. Now, patients have dementia. So after 3 months intervention, we have look into the psychometry. Also, the sound is composed of four tiers, is more reasonable. So you can listen to the sound without the noise. So it's a 4 tiers sound and 4 tiers light. We use this one to intervention for dementia patient. That's published data accepted as an oral presentation. After 3 months intervention, such intervention will improve in the MPS scale. So we decrease the depression and lower the caregiver burden. And we are going to check the plasma biomarker. So I would say this digital intervention may be a new and more comfortable, acceptable for dementia patients. We also have tested this one in depression and sleep disorder. In our center, we have changed the light. All light are changed into the 40 Hz. So patients come to our center, maybe enjoy and feeling the different surrounding. And maybe if next time, if everyone come to my Cultural Medical University, we welcome to the center to enjoy the different feeling and surrounding. All the light have become the 40 Hz. So we have remodeled our building. So we have some lessons from the SCS study. I think SCS could be the specific target that we should prevent acute intervention. Then we have a higher proportion of ApoE4 carrier. Then we are the A-beta plasma 40-42 change. Also have beta-1A1, higher possibility of amyloid positive. Should be examined and cared more casually in the near future. And thank you for your attention. Thank you.
Thank you. Thank you, Professor Young's very interesting talk. We can use the light and the sound to prevent our prevention occurrence. Now, we open to the audience. If you have any questions, any comments, you can raise your hand, and we invite all of our 4 speakers come up to the stage.
Yes, please identify yourself and ask the questions.
Thank you all for your nice presentation. I have a question to Gustavo. I'm a hidden arrived from NGG Japan. You mentioned about the COP cells, the role of COP cells on frailty and osteoporosis. I understand COP cell is associated with osteoporosis, but I'm not so sure what the mechanism that affect the frailty in the presence of low COP cells.
This is a very interesting question because it's not only reduced in osteoporosis but also in sarcopenia.
Yes.
It's associated with low muscle mass, low bone mass, and it's associated with frailty. What we think is that there is, in the normal aging, there is a steady number of COP cells. That means that there is no stem cell depletion or exhaustion, which is one of the hallmarks. And therefore, and we already looked at healthy volunteers from 20 to 100-year-old, and we found that the population is very steady. But in this kind of stem cell exhaustion, when the population of stem cells tend to go down, then a lower number of those cells reach the circulation. And that's why we clearly find this an indicator of deterioration in muscle, bone, and therefore in the whole frailty context.
So we are working on the effect of mesenchymal stem cells on frailty and sarcopenia. So, but we are not so sure the mechanism. The stem cells might increase the decrease the chronic inflammation, and also maybe provide some good cytokine to improve muscle health. So, do you think you can purify COP cells in the plasma or bone marrow and administer the COP cells to the patients?
I'm smiling because this is exactly what we're doing now. We are, the good thing about stem cells from COP cells is that they can be easily taken from the circulation. You know, we actually take it from the buffet coats, from, the trash that the transfusion and all the other elements are extracted, all the rubbish. In that rubbish, the stem cells go there. So what we do, extract them, we develop the method to expand them and multiply them, and we are in the process now of starting the clinical trial infusing stem cell, COP cells, not stem cell, COP cells in people with osteosarcopenia and frailty.
but you need a lot of volunteers to collect COP cells with a sufficient number.
That's the good thing, is that now we develop the method to expand them. So we can have, even if the normal number of COP cells is 0.8% of our PBMCs, we can produce up to 200 million cells very quickly.
Okay, thank you.
Okay, we got a question from there.
So there's a lot of discussion so far about Alzheimer's disease, but in Asians, it seems that, from what I understand, that Alzheimer's disease is not the dominant form of cognitive impairment in these countries, and in fact, it's more primarily vascular related. So how do these biomarkers that you're talking about relate to prediction or identification of treatment for that large part of the population in Asia that is not Alzheimer's disease?
Yeah, Dr. Yang, looks like ask you.
Sorry, can you specify your question again? You mean that many factors did not contribute to Alzheimer's dementia. So how can we manipulate that? Am I wrong?
I can clarify the prevalence of the type of the dementia in Taiwan. Actually, the predominant type of the dementia is the Alzheimer's disease. No problem, because we have done the community survey, community dementia survey, and we found that more than 60% of the dementia is Alzheimer's disease type. For the vascular one, is the second largest portion.
We know the most common, the most common type is also dementia or Alzheimer's type. But the 20 to 60 of these participants have vascular contribution. But it's Alzheimer's dementia with a vascular contribution. It's Alzheimer's dementia, not the vascular dementia. The vascular factor we can control, but control this factor, we decrease the prevalence of AD. So in the Asian country, it's still Alzheimer's dementia is the most common one.
And just one other comment. There is a low rate, I believe, in Asian countries of neuropathologic examination. So we have clinical diagnoses of vascular dementia, and eventually we'll know through the biomarkers about the true frequency of Alzheimer's disease. Once again, I come back to the issue of people who participate in biomarker studies are not representative of the general population. So I know that there have been many studies of what the predominant etiology or etiologies is of dementia in Asians. There was a particular study some 25 years ago of Japanese individuals who the clinical diagnosis, just as the questioner indicated, found vascular dementia to be the predominant clinical diagnosis of dementia, but individuals who are of Japanese heritage and moved to Hawaii, and then others who moved to Seattle, the shift changed into Alzheimer's disease. But once again, I would put a big plea out for either in vivo biomarker studies to determine whether people diagnosed with vascular dementia may also have an Alzheimer's component, and eventually neuropathologic studies for confirmation.
Okay, but you know, the Japanese or Asian country, highly incidence of the white matter hyperintensity microvascular disease. So we have to pay attention to how to keep or secure cognitive reserve. And however, the intervention, for example, for the cognitive rehabilitation is very effective, not also on MCI, but also the vascular dementia. So in recent good news from RI, even if the APOE4 area, the cognitive multi-domain intervention is effective in respective of such a biomarker. It's a good news.
Yeah, other question there.
Thank you all for a very promising speech. And I have a question for the Dr. Gustavo. It's very promising that quinoline has the effect on the CNS and also healthy aging. And as I know that the tryptophan pathway also includes indole, not only tryptophan and the serotonin. And the indole pathway also associated with the HR receptor. So I don't know what's your opinion on this one, because it seems that the quinoline and indole has all the effect, maybe affect the healthy aging and also the brain. Thank you.
Yeah, thank you for the question. Yeah, there's a clear connection there between quinoline, indoles, and neurotransmitters, and we know that basically the one that clearly affects that is associated with neurodegeneration is the quinoline itself and the quinolinic acid. Those are terrible metabolites from the quinoline side, because as I mentioned, we have three pathways there, but the most important or the prevalent 95% of the metabolism of tryptophan is through the quinoline pathway. So when that's affected, and it's very much dependent on the health of the microbiota. So the indole, quinoline, all these are really related to the levels of inflammation that the person has. And we find a clear correlation between inflammatory markers, microbiota deterioration, and high levels of quinoline, and at the same time, high prevalence of frailty, neurodegenerative diseases, and osteosarcopenia as well. There's a clear relation.
Thank you very much for your answer. And the following question is that, do you find any ways, like a microbiome or other diet and intervention to change it? Because we know that there is the good side in the quinoline pathway and the other side. Thank you.
It's a very interesting question, because we are in the process of administering probiotics that help the content to have a healthy microbiota, to improve the microbiota, the profile of the microbiota, and those probiotics induce the release or the metabolism of anabolic metabolites, such as picolinic acid, such as NAD+, all these anabolic metabolites from the quinoline pathway. So that's from the therapeutic perspective. For the future, we think that will be the other point that we are now doing is, or the other approach is, we are administering the actual anabolic metabolites. So we are directly administering picolinic acid. What is clearly demonstrated is that just increasing the intake of tryptophan is not going to have any benefit or any change, because at the end, if the alteration is in the inflammation and microbiota, then it will end up becoming quinoline anyway. So we are trying to approach it in a different way, more anabolic and more geroscience perspective, I would say.
Thank you very much.
Thanks for all the guest speakers, distinguished speakers. I'm Dr. Chen from Kaohsiung Medical University, and also affiliated to National Center of Geriatrics and Welfare Research. I have questions to Professor Kenji Toba, that you present the secular trend of the proportion of severe dementia who needs care is declining. And so I'm wondering how you measure that they don't need the care, because you say the proportion of the people with severe dementia who needs care is declining in the secular changes. So I wonder how you measure their care needs. That is the first question. And the second following question is about how you change your resource allocation in your long-term care system for the people with dementia, responding this secular change. Thank you.
Okay, first question. Do you know the system of the long-term care insurance in Japan? You know? So every user of the service should take the examination of the level of dementia. So checked by maybe some home doctor or something. So the level of the dementia, the classified five levels, independent and some with some assistance or something. And area need assistance level 2 is in all over Japan, the registered every year. So it's national data. Is it okay? And the second question, I can't sorry follow.
So regarding you said that you measure that the proportion of people with dementia don't need care. So how you modify your resource allocation in your long-term care system to responding this change?
Care worker, no? Okay, sorry. The almost 10 to 20% of care workers resign or leave their jobs because of the salaries too low and the working condition is so severe. So is it okay? So and only the 30% of such a care worker return to go to another care worker or nursing jobs. Others go to another job. So decreasing year by year, it's very serious. And compared to the other jobs, the monthly salary is cheaper than $400 US monthly.
Okay, we have another question from the audience.
Hi, I'm Xiaoyu Yang. I'm professor at National Taiwan University, and my specialty is epidemiology. So I'd like to ask the question about the study design to explore this biomarker. From your speeches, since most of the study for this biomarker come from cross-section study, and my question is how do you select the healthy control in your study? Some study use hospital cases as hospital patient as the cases, but the control might be come from the nearby community. But these two groups belongs to a reference population. So the higher biomarker in this case group might not specific to the Alzheimer's disease. Maurice's study showed me he used a cohort study, prospective cohort study to explore this biomarker. But I also curious about, do you use repeat measurement to compare the concentration of this biomarker in different stages of these patients? Thank you.
You are going to ask Professor Morris, right? Because every speaker are so nervous, you did not single out which one you are going to ask. So please, Professor Morris.
I think your questions are good ones. In our particular cohort, I've already indicated that they are not representative of the population. The individuals who volunteer are from the community, not from a clinic-based population. Their study partners typically are their spouses. So this is how we recruit our participants for the biomarker studies. We do longitudinal collection of the biomarkers. We get them at baseline and then every 3 years thereafter. The plasma biomarkers, we're doing it every 2 years thereafter. And so we do have a great deal of longitudinal data on the biomarkers. They don't change in that sample that I've described.
Any other questions from the audience? Yes, our boss, Situ, Professor Situ is asked.
Yeah, we come from NHI. So thanks a lot for all of the excellent presentation for the four speakers. I just have one quick question for Professor Yang. So in your final part during your presentation, that's a very interesting approach. Those cultural cells treated with the light or different sounds. So I probably missed some background information. So any non-receptor or potential adapter or interacting protein which can receive such kind of signal then cause the subsequent impact for those cells?
Very good question. Actually, we don't know. But I can support some data. We have duplicated study into the kidney cell. It doesn't function. We duplicate study in neuron cell. It function. So I can know the different cell have different receptor, but so far, actually we don't know that. This is definitely I don't know quite answer whether the receptor is. But different cell have different response. That's true.
Okay. Any other questions? Let me. Lim, Professor Lim.
Yeah.
Yes.
Wee Xiong Lim from Singapore. Question for Dr. Morris. Yeah, thank you very much for the excellent talk. My question pertains to the paradoxical finding of lower amyloid positivity in the Blacks and Hispanics. Could this be explained through the lenses of cognitive reserve, such that, for example, the non-whites have a reserve due to microvascular disease, social determinants, or other factors, and what then would be the implications?
Yes, thank you. So the lower rate of amyloid positivity in blacks from non-representative cohorts. Our particular black individuals also have a mean educational attainment of 16 years. They're college graduates. So they may be less affected by social determinants of health because they are a more privileged group. We don't know the answer to your question, why there is lower biomarker positivity in blacks who participate in biomarker studies, but I suspect it probably is they're not representative of the general black population.
I have a question to Professor Morris. So in your study, I was surprised to see the higher prevalence of ApoE4 in your cohort compared to the Asian cohort. In Japan and Taiwanese cohort, the prevalence of ApoE4 is about less than 20%, but in your cohort, more than 30%. So I'm just wondering if you divide the cohort into 4 groups based on the presence of biomarkers and also ApoE4, did you see the different trajectory in your follow-ups?
That's a very interesting question. We haven't done that, but we should do that to see if that's the case. And it is true that ApoE4, again, has been predominantly characterized in white populations. We know that it has less of effect in blacks, African Americans, and Asians, so it can't be all social determinants. I think there are some genetic variants that differ among different populations. We must evaluate these different populations to fully understand the spectrum of Alzheimer's disease and its antecedents.
So in your cohort, healthy lifestyles affect the outcomes, and I mean the incidence of dementia. Did you check the lifestyle like exercise or nutritional intake in your cohort?
We are doing a study now of physical activity, and I don't have data on that, but yes, I think lifestyle is very important. But in my practice, I tell my patients, and perhaps others have this experience, to eat a heart-healthy diet and to stay physically active, mentally engaged, and socially connected. I mean, whether they all work, I don't know, but they don't hurt.
It is a common educational approach for people with cognitive decline in the States?
Yes. We've got a question from there. Yes, please.
Hi, my name is Angelique Chan, and I'm from Singapore, and I run one of the national representative longitudinal cohorts for the country. I'm a sociologist, so I focus on the social determinants of health. We're in our 3rd wave. I'm collecting data on 10,000 older Singaporeans, 60 and above. And my question is, how, in terms of conversion rates, if we're finding people with MCI now, how long should we be studying them to see conversion to dementia or Alzheimer's?
Thank you for that question. I don't have the answer for you, but I would think that people who are considered to have mild cognitive impairment, two things. One is in our experience, within 5 years, if the reason they have MCI is underlying Alzheimer's disease, they will have progressed to a more symptomatic stage, more severity, if Alzheimer's disease is the underlying problem. But about a third of our people in that stage are reverters. They go back to cognitive normality, or they flip-flop back and forth. So it's a very interesting question. I don't have all the information, but I think, again, now that we have molecular biomarkers of Alzheimer's disease, we can tell with better certainty people with MCI due to Alzheimer's disease if their Alzheimer biomarkers are positive. And I think within 5 years, they should progress to more severe cognitive impairment. How long do you follow them?
Well, we started the cohort in 2016, and we plan to we're doing wave 3 now, and we're going to do another wave 4 in 2026. So
great. So next year, you can be up here, and then we can ask you that question.
I have a question to Professor Yang. You just mentioned in ACS study, if the parents have the Alzheimer's disease and you do the PET scan, and you predict for the children, they have 44% of their children have potentially have a PET scan positive, right? But however, I found that in your whole the patient pool, you only include 18 patients into the study. Do you think it's a little bit overestimated? Because in clinical part, for those who have a highly potential to develop dementia, the clinician or their family can afford or advise the children to take the PET scan.
Actually, I have to say we have a limited sample. So this is a convenient sample, just report the data. I just highlight one important issue, the ACS, under very high risk of dementia. But true rate, actually, we just provide our convenient sample. In the world, I think there are another cohort in Washington University in St. Louis. May I forward this question to my mentor, Professor John Morris? How about amyloid PET positive in your ACS study, the ratio?
I'm sorry, how many ApoE4? ApoE4
PET positive. PET scan.
Amyloid PET positive, and how many are ApoE4 positive?
How many? I mean, the ratio of amyloid PET positive in ACS study in Washington University.
It's 50%. 50.
Yeah, I got a question to Dr. Yang. I'm interested in your ACS family's mother actually dominant than the father side, right? I'm a diabetes doctor. Similar happen in diabetes. We call that penetration, whatever term. So what's the reason behind? Can you make a guess?
I think the genetic heredity gene is similar. So the gene will have a similar protein performance. So basically, for the gene protein, I think that's similar to the pathway. Also, another possibility. Do you have an answer? Maybe other answer we don't know. Actually, I don't know, but I just identify this is true.
One of the reasons in diabetes is mitochondrial DNA, which only pass from mother to the offspring. I don't know. Yeah. Another explanation is actually the lifestyle penetrate to the children. Most of the mother actually influence more than the fathers in the regular families. Yeah, in many countries. For example, how the children pick up their favorite food, exercise habits, which I believe mother's habit actually is more dominant than fathers.
Actually, we know that mitochondria in dementia is heterogeneous. The role is not definitely. So probably, I think the female still a higher risk for dementia. Maybe many reasons. You can looking for a publication, a children education, many possibility. But also many possibility we don't know.
Yeah. So following that question, when you see the ACS families, their offspring, you do the protein biomarkers in their serums, right? Did you divide men or women offspring? Is there any differences between sexes?
Actually, my data no difference. No difference in gender for the biomarker. No. How about what you?
We are just beginning to look at potential sex differences in our cohort. I showed very briefly a slide from the phase 3 study of lecanemab, and it wasn't powered to look at sex differences, but it seems like women respond less to that amyloid clearing drug than do men. Now, we need a much larger cohort sample to be able to determine if that's really the case. But I think, along with many other questions, that sex differences in Alzheimer's disease have been underexplored. We always thought that women were more likely to develop Alzheimer's dementia because they live longer, but maybe there's more to it.
So also we saw many presentation of the whatever from DNA methylation to the proteomics, but we did not touch a very popular issue is polygenic risk score. So perhaps Maurice, you can discuss how the impact of polygenic risk score in prediction the development of Alzheimer's.
Yes, we do find that polygenic risk score does predict the eventual development of Alzheimer's dementia. It is not as strong a predictor as an amyloid positive PET scan or a plasma A beta 42/40 ratio, but yes, it does predict.
Okay, any other question? Yes.
Sorry, I have a last question. I'm Emily Yitingling from Kaohsiung Medical University, and my question is for Dr. Morris. I have you mentioned about the plasma protein tau 1A1 and 271 for the detection of the amyloid status, but for the other group, like a specific disease group, like a CKD group, we talk about that renal function may affect it. And for the other, like liver disease or kidney disease, do you also recommend that we follow this kind of plasma proteins?
Yes, that's why the ratios, I think, are important, because they do try to correct for hepatic disease or renal disease, which does affect the concentrations. So we use the A beta 42/40 ratio because it's much better for adjusting for those metabolic problems.
Thank you very much.
Looks like we have a fully discussions of these sessions, so I would like to close this session by thanks all the speakers for their very comprehensive, very informative speech. Let's give them another round of applause, please.
Thank you, Professor Toba, for a wonderful talk. Thank you, Professor Toba. Thank you, Professor Morris, for an excellent talk. Thank you, Professor Yang, for an informative talk.